Good morning, everyone, and I would like to thank the AUS for giving this opportunity. And I want to share my experience in surgery with advanced proliferative diabetic retinopathy. Why is it required? I have no financial disclosures to make. Diabetes definitely achieved a epidemic proportion, and the number of diabetics walking into our clinics is really increasing day by day. And we should be very well equipped, not only for handling the mild to moderate non-proliferative diabetic retinopathy, but advanced PDRs and advanced PDRs. Diabetic retinopathy, everyone knows that it passes through different stages, and at early proliferative diabetic retinopathy, we can prevent the blinding complications. However, somehow we are missing that in our country, and the patient lands up with a very advanced proliferative diabetic retinopathy. So it's by letting the patient go into the advanced proliferative retinopathy, we should be well equipped for the vitreoretinal surgery, and let us see how it can be handled. This is a case where it's a simple kind of a proliferative diabetic retinopathy with definitely there are so many, the neovascularization is there and a mild subclinical traction is there. And as usual, this patient undergone panretinal photocoagulation. But within 3-4 weeks, the patient lands up like this. This is purely, if you see the middle photograph, there is a regma formation post laser, and this patient landed in advanced combined retinal detachment. So this can be a common occurrence post laser. So one need to be prepared that in case of eventuality, you should be able to handle. So we have done the vitrectomy, and this is the outcome. The vision, though it is 2025, she recovered to 2080, and then little bit of cataract later on it was handled. We see the proliferative diabetic retinopathy with a lot of traction. Though there is no highly vascular component, there is a traction which is threatening the macular center where you need to intervene and give a stability, which in these patients on long-term basis is very, very essential. This is an engineer who came with a bilateral advanced proliferative diabetic retinopathy. Both eyes vision is 20/200 and 20/400, and he's out of the job. This patient, we have intervened one eye after the other, and fortunate to me, he stabilized and his vision gained at 20/30 with a near vision of N6. I put him back into his profession. It's mainly I saved one family from bankruptcy. Proliferative diabetic retinopathy with a lot of macular fibrosis. I always call it as a premacular fibrosis, which again requires a surgical intervention. And this is another example of that. And with intervention, you can not only stabilize the proliferative diabetic retinopathy, but the field you can improve a lot. This is very essential in stabilizing. And some tractional detachments where the central macula is attached, but there is a severe traction which in near future can compromise the macular health. Such patients should be intervened surgically. This is the outcome of that same patient. And in subhyaloid hemorrhage of proliferative diabetic retinopathy, one need to understand that the posterior hyaloid is very thick, and a YAG hyaloidotomy may not be sufficient. And second is, in these cases, by YAG hyaloidotomy, you are not addressing the primary pathology where there is a proliferation and ischemia. So surgical intervention always a good option to stabilize the eye and give a good visual outcome which is long lasting. And this is very type 1 diabetic female of 23 3 years with came one eye I operated, and the second eye she came all of a sudden with a severe drop in vision, and we have done the vitrectomy and stabilized this eye. That way, we always do a surgical intervention to stabilize. And this is another specific indication of anti-VEGFs in before surgery. And when there is a vascular component which is very predominant, intraoperative hemorrhage can be a big possibility. And to avoid that, you can see very first post-op day picture how bloodless it is after the surgery. And when you are dealing with advanced PDR, you need to see this patient if the vision, it is relatively good 20/60 vision, but he was fumbling and coming to the clinic because the loss of field. And he's a businessman in South Africa, and only eye he is having, so we intervened and he got 20/50 vision, but more importantly, he's confident in moving around. And this is ultra advanced. You cannot imagine such cases can come. And bilaterally, he was intervened, right eye only 2 meters outcome, and the second eye 2200. But visually, he's been comforted. And all surgeries do not mean that it will only end up in good outcomes. This is post VR surgery with a traction retinal detachment. Again, we intervened and stabilized. This is in the other eye, which again with a large retinal break. It was done in one of the premier institutes. So we have again intervened and stabilized. Though he got 2200 vision, it is a stable retinal status that is more important in these cases. So I would like to conclude that prevention of advanced stages of proliferative diabetic retinopathy is very, very essential. However, if the patient advances to an advanced proliferative diabetic retinopathy with secondary complications, we should give a good stable outcomes with VR surgery. Thank you very much for your patience.